So good afternoon everyone. So we will continue with the previous session. Two talks were left behind. So one was basic workup of LASIK and PRK. There is another talk also. So how many of you have actually seen the LASIK being done? Just raise your hand please. No, GMCH को छोड़ के. Outside students. Okay. So I'll be just discussing the very basic things which you must know, because actually you have not seen the LASIK. So surgical part I will not discuss much. So I will just tell you, if patient wants LASIK, what are the things which we must do before going for LASIK surgery. So as you know, there are different types of refractive surgeries available nowadays. So that can be cornea based or lens based or bioptics. So like cornea based, there are so many surgeries, like almost 30 years back, radial catotomy was the only surgery that was done, so which is obsolete now. So then nowadays there is PRK, LASIK, epi-LASIK, LASIK, smile, conductive keratoplasty, and corneal rings, which are used for keratoconus. So I'll be just focusing on two things which are most common, that is LASIK and PRK. Rest of things I will not be able to take because of shortage of time. Then lens-based surgery are like phakic IOL, what we say ICL implantable contact lenses, then clear lens extraction. Then bioptics means when two procedures, one is cornea based and other one is any other procedure. So when these two procedures are combined, that is called as bioptics. So whenever we are planning LASIK surgery, so what is the most important thing for going for surgery? So first thing is motivation of the patient, because all these are very cosmetic surgeries. So patient is actually absolutely normal. So his eye condition is normally, except that he is wearing glasses. So whenever we are touching normal eye, then we must be 100% sure that patient must be fully satisfied after surgery. So for that, motivation of the patient is the first thing. So we should not try to actively motivate the patient. Rather, patient should ask us that I want this surgery because of this, I don't want to wear the glasses. So then only, if the patient doesn't want and you say that you are wearing glasses, so better get this surgery done and you will not need glasses, then the patient will never be satisfied because he doesn't want. That is, you are motivated. So primary motivation should be from the patient only. I think that is the most important thing. Then other things, if you tell to the patient, if the patient is knowing each and everything about those things, if a result which is 100% not achieved, then also patient will be almost satisfied. So this motivation part is very, very important. Then age is another thing, like we must operate patient not before 18 years of age for LASIK. There are few other optical indication where like if we want to achieve binocularity with the strabismus or something other like that, then in children LASIK can be done. But otherwise where there is a refractive error, only no other problem in the eye, then it should not be done before 18 years of age. And then whatever refractive error is there, that must be stable. So the stability of refractive error, that is again very important. If the number is still progressing, then no point doing refractive surgery, because immediately you may achieve good result, but later on again patient will develop a refractive error for which patient will not be satisfied. So stable refraction is important. Then amount of refractive error, that is another important thing, because I told you many types of surgeries nowadays, lens based or cornea based, are available. So we have to choose which surgery is best for that particular type of refractive error. So as far as LASIK is concerned, the ideal situation for myopia will be up to 14 diopter. In fact, that is the highest range. If you see practically, it is almost, I will say 2 to 6 diopter, that is the ideal range. Beyond that, you can give good results, but not excellent results. So, but depending on the types of machine, up to 14 diopter can be corrected with the almost 5 diopter cylinder also. And hyperopia cannot be corrected more than 5 diopters. So nowadays we are doing hyperopic LASIK also. So we can correct up to 5 diopter in hyperopia as well. Then astigmatism, sometimes there can be sphere, cylinder both. Then up to 6 diopter, that is also again the highest range. Otherwise, most of the time what we have seen, if the spherical error is more than the cylindrical, only then you can give good results. If cylinder is more than the spherical, then chances are it will not be giving good results. So up to 6 diopter cylinder, again maximum limit, otherwise up to 4 diopter, that is the ideal for which we can go for LASIK. Then whenever we are operating these patients and we are going for workup of various things that I will discuss subsequently. So contact lens, if the patient is wearing, that must be discontinued, because whatever test keratometry or pentacam you will do, so that will not give accurate reading if a patient is wearing contact lenses. So we must discontinue contact lenses at least 3 to 4 weeks for rigid, and with the soft lens, then it must be for at least 1 week to 2 weeks. So there is a long list of contraindications for LASIK. So I'll be just telling important things like absolute contraindication where we should not go for LASIK. That is keratoconus, advanced keratoconus, definitely no. So in this situation, because there will be so much abnormality and patient will not be satisfied and you cannot give normal vision. So keratoconus is the first thing. Then whenever there is a cataract also in some like developmental cataract or some other type of cataract is there, then also you should not think of doing LASIK surgery. Then glaucoma is very important. If there is a uncontrolled glaucoma, because in these patients we are going to raise intraocular pressure up to 65 millimeter of mercury. So because of that, if there is advanced glaucoma already there, so patient may go blind also, because there is a transient rise of pressure in these patients when we are doing LASIK procedure. So it is very important that glaucoma must be excluded by various tests. Then various autoimmune conditions, then posterior segment conditions like a retinal detachment or anything that must be seen, because these are high myopic patients most of the time, so they may have some peripheral break or a tear or detachment also sometimes. So posterior segment must be examined thoroughly. Then other thing is excessive steep or the flat cornea. These are again two big problems. Very flat cornea, patient will develop free flap. Very steep cornea, there will be buttonholing of the flap. So again, these two extreme situations I will tell again later. So then there are so many other like pregnancy, lactation, because here the effective area keeps on changing. So even dry eye also. So all these conditions which I have highlighted, so they must be seen thoroughly. So whenever we are planning, then we must discuss with the patient what we are going to do in the LASIK also. So whether it is a femto based flap or it is a Moria keratome or any other microkeratome, because that is also very important. Sometimes if you don't tell the patient will say, I didn't like this keratome type flap, I wanted this laser type flap. So we have to discuss with the patient before you plan whatever you are going to do. So technique should be told to the patient. Then expectations, what you are going to give. In that you must tell that we are going to do surgery, but we cannot say 100% that you will become 6'6" after surgery. If you are telling 6'6" after surgery, then I think you are telling lie, because no one can guarantee before surgery that you will get 6'6", because it may be 6'9", it may be even less than that also. So there are all these things, they are calculated by the machine. So machine may not be 100% accurate all the time. So we must tell to the patient that these are the things, these are the possibilities, and even complication, those also we must tell. So that like if you are making flap, especially with the blade, or even the femto also, so you must tell that these are the complications which can happen during the surgery. So if you don't tell these things, then definitely if something happens, then patient will catch you. So it is very important that we must discuss in detail each and every aspect of the surgery. And then other surgical alternative, like patient has got -8 myopia, so you can tell about ICL also, which is a reversible procedure. So we should tell alternative options, even contact lens also, that also should be told to the patient. So if you tell all the pros and cons of the patient before going for surgery, then whatever happens, then at least patient will be satisfied that everything was told to me before surgery. Then we must tell whether you will become free from contact lens or free from glasses 100% or not. So then profession is very important. What type of profession patient has got. So sometimes he may require very crisp vision, or some like he wants to become pilot or some other thing. So depending on those situations, like if a patient wants to go for defense services, where 6'6" vision will be mandatory. So you must tell that what I'm going to do, this will be the result. So profession is again very, very important. So whenever we are planning, so what is the pre-operative workup, that should be done very thoroughly, only then you can tell. So like general medical history. So diabetes ruling out is very, very important, because diabetic patient, they can have unstable refraction, they can develop early cataract, even the healing problem, flap may not heal at all, it may not get attached. So we must exclude diabetes. Then pregnancy already stressed, that should be ruled out. Then autoimmune condition, they are also very important. So first one must try to find out any systemic history. On the basis of that, you can know whether there is some autoimmune disease or not. So if that is there, especially like collagen vascular disease or some muron or something like that, which is causing peripheral corneal problem. So then that will cause problem in the refractive surgery also. So we must know any systemic history which may subsequently cause problem to the cornea. So immunodepressed patient, then any patient having some allergies or any systemic infections. So there are so many drugs which cause healing problems. So all these things must be ruled out. Then another thing is monocular, like one-eyed patient is there. So then better not to go for any surgery if patient is one-eyed. Otherwise, PL negative or whatever, some disease is there. So we should never operate if the patient is having just one normal working eye, because you don't know what can happen. So it is always better to operate when the patient has got both eyes having normal things without any other disease. Then post-operative blepharitis can cause a lot of problems. So we must see the lid condition very, very thoroughly. Any stry or any blepharitis, squamous or ulcerative, whatever type, so that must be seen very clearly. Otherwise, this minor problem of the lid will cause post-op problem, and those are very serious problems. They may affect even the vision also. Dry eye is very, very important. So we should never operate any patient for refractive surgery if there is a severe dry eye. In mild dry eye, what we do, we try to first treat the dry eye part for few months. If all the parameters they become normal, only then we can operate. But moderate to severe dry eye, I think they should be contraindicated, because any refractive surgery procedure, especially PRK and LASIK also, they induce dry eye themselves. So any previous ocular surgery, like any RD surgery, vitrectomy, cataract filtering, bleb is there. So all these things, they should not be operated because they are going to cause ocular surface problem. So because of ocular surface issue, patient will never be satisfied. So any patient already undergone radial keratotomy, so then naturally surgery cannot be done. So again, these progressive conditions and chronic condition, like even recurrent corneal erosion syndrome, where patient develops recurrent corneal erosion. So these patients, they are not good for refractive surgery, especially PRK as well as LASIK. Then progressive, as already told, we must have stable refraction. So during surgery, there can be problem in certain types of patient, like sunken eyes. So it is very, very difficult to make the flap, because then suction ring application, that will be a very difficult thing. So we must see the patient beforehand, whether his eye is not that much, too much sunken also. Very narrow palpebral aperture, then again it will be a problem. Blepharophimosis and all these things, they must be looked for. It is not that we just see the cornea and then start operating. So if you see all these things, then only you will be comfortable while doing surgery on the table. Blinking is again very important. If there is not a normal blink, then again we can have problem, especially patient may develop dry eye. So we must ensure that patient blinking is normal. So then anterior segment, all these things, they must be ruled, especially intraocular pressure already stressed, then corneal sensitivity. The lacrimal function again very important. We must exclude chronic dacryocystitis. Okay, so if there is an NLD block, so never ever think of doing any LASIK surgery. First treat NLD part, then only think of going for corneal surgery. So again, told all these dry eye tests, they have to be done thoroughly. Glaucoma is very important. The pressure is too low, then also it will be a problem. If pressure is very high, then also it will be a problem. So patient must have normal intraocular pressure without any medication. It is not glaucoma controlled with medication you go for surgery, because all these anti-glaucoma drugs, they also cause dry eye. So whenever we are planning LASIK, patient should not have any glaucoma. Normal tension or any glaucoma, that should not be there. So definitely fundus examination, because all these are mostly myopic patients and very high myopia also. So periphery of the retina, that must be thoroughly examined. So there should not be anything which if there is some hole or some break, that must be treated first. So you can go for LASIK surgery later, but first treat this thing, because if you do LASIK surgery and patient was having already some break or the hole and subsequently develops RD, so patient may correlate that with LASIK surgery. So we must first treat all these breaks or holes. But if there is RD, then no LASIK surgery should be done. So this is very important. So once you see the keratometry, they immediately first see what is the value. Only after that you plan surgery. Especially I'm saying about the LASIK part. If there is a very flat cornea and you find it is less than 41 diopter, never ever think of doing flap type of surgery, because patient will have free flap. Definitely if you do operate at 40 or 41 diopter, there is no chance that flap will be normal. So it is very important that never operate with keratometry less than 41, and similarly any keratometry more than 47, again you will have buttonholing of the flap. So we should not try to do flap, especially by the microkeratome in these situations. Then irregular astigmatism, again that is very important to know. So all these things, they will be known by doing various other tests like keratometry. Then reflection, again very, very important. So how much refractive error is there? Don't rely on other finding that patient has got this much refractive error. We must do cycloplegic refraction ourselves. So if we do not do cycloplegic refraction, then subjective it may be different. So then whatever correction you are doing, that may not be correct. So it is important that we must do cycloplegic refraction properly, because that will be the main thing. On the basis of that you are going to give the results. And pupillometry, again important, pupil size. Because if the pupil size is big and your optic zone is small, then patient will have a lot of glare. So large pupil size, there will be big problem for the LASIK surgery. So ideally pupil size should be 3 to 4, maybe 5 maximum. More than that, then we have to plan surgery, but in a different way, and telling the problem to the patient that you may have glare and other problems also. So this is the performer, like if we make some performer in detail like we have made in our department, so we fill all these things whatever I am telling. So everything should be in writing so that you do not miss any examination part. Once you write each and everything on the file, then see the file before going for surgery, then you will not miss any finding. So all these things, they should be written thoroughly. So after doing this, then we should plan the surgery. So in surgery, what are other things which must we should think of? So that is a residual stromal bed. So that is very, very important. So what is residual stromal bed? That is central corneal thickness minus flap thickness what you are going to make, and ablation depth. So once you deduct these two things, then it should be more than 250 micron. Practically what I am doing, I try to ensure that it should be more than 300, because 250 and 300 it is a borderline thing. So where there can be keratosis after a few months or a few years. So best will be if a residual bed is more than 300 micron, then there is hardly any chance of any problem later on. So then there are a few other formulas also. By that you can know how much flap thickness should be there. And this percentage tissue alteration, that is again very, very important. So what is that? That is flap thickness plus ablation depth. So if you divide it by the total thickness of the cornea, then it should not be less than 40%. Okay, so if it is less than 40%, that means residual bed is very less, then 100% patient is going to develop keratosis. So again, we should not compromise in these two things, residual stromal bed and the percentage tissue altered. And the hyperopic LASIK, again, we have to have few consideration, but here because the cornea is usually not that thin, so residual bed will not be a problem. Only problem will be how much correction we can do and how much correction of one diopter will going to cause correction. So that we can see the type of machine which we are using, that will tell exactly. Similarly, LASIK with astigmatism. So here the problem is we have to convert first the whatever astigmatism is cylinder, that should be converted to the minus power, and then we have to calculate, and then total refractive error, that should be sphere plus cylinder, both should be added, only then we should consider, not that only sphere. So after adding both, then we should see how much ablation will happen because of that refractive error. So these are the problem areas: flat cornea, small orbit, post PK, post radial keratotomy, post antiglaucoma, felting surgery. All these situations we should be very, very careful. So technique, just I will tell the brief points. Like head must be thoroughly fixed. Then microkeratome should be applied with the suction ring. So once you apply this suction, so what will happen if the suction ring is properly applied? There will be pupillary dilatation, and patient will say, I am not able to see. There will be blurring of the vision. So if pupil dilates and vision blurring, that means suction ring is properly applied. Otherwise, if the suction ring is not properly applied, then what will happen? There will be a problem to the flap. It may be free flap or buttonholing of the flap or incomplete flap. So in the suction, most important thing will be we have to see dilatation of the pupil. Then microkeratome, there are so many types. I don't want to go into detail of that. So one can use whatever microkeratome have, and accordingly you should know what is the technique of applying that microkeratome. Then there are different type of nomograms. Accordingly, you have to decide what type of this microkeratome you have to use. So that will depend on the size of the cornea and the keratometry. So these two things will decide what should be the size of microkeratome and the type of machine also. Like we have Moria microkeratome. So where we need two things. One is keratometry. Other thing is the overall size of the cornea. So accordingly we can decide that. Excimer laser, then after making flap you have to do the excimer laser ablation. So these are two steps. One, first making the flap, then putting the excimer laser beam. So again, for that there are so many techniques. Then after that you reposit the flap after thoroughly irrigating the surface. Then just replace the flap, and over that you can put bandage contact lens, or some people do not put bandage contact lens. So per se surgery is not that easy. Is a difficult. Surgery is very simple, just making the flap. But technique of flap, that is the main thing which requires a lot of practice. And then applying laser is not very difficult. Then after that just put bandage contact lens. Then I don't want to go into detail of this aberrometry. Then just few words about PRK. So pre-operative preparation will be same for LASIK and PRK. Only thing is technique of surgery is difficult. So what is basic difference between the two, LASIK and the PRK? So in the LASIK we create the flap, but in PRK what we do, we just debride the epithelium. So because of that, post-op there will be lot of problem to the epithelium, means healing will take some time. So patient will be highly comfortable in LASIK, while in PRK patient will have some pain. In fact, some patient they are very sensitive, they have a lot of pain for initial 48 hours. Then this persists for maybe 2 weeks, and there is some little bit corneal heals also in PRK which is not there in LASIK. So that is the main difference. So recovery will be faster in the initial phase in the LASIK, in PRK will take some 2-3 weeks, but ultimately the end result will be same for both. So there is no difference of ultimate outcome of the vision whether you do LASIK or you do PRK. So patient will be very comfortable because there will be no pain in case of LASIK. Then low to high myopia and the thicker cornea go for flap making. PRK will be good where the cornea is thinner, where you are not able to make flap, and the stromal bed will be less. So there you can go for PRK. Or patient has got some recurrent corneal erosion, some other epithelial problem. So there will be that will be more suitable for PRK. So contraindication, like these are the best situation for PRK, like form first keratoconus, because cornea will be thin, so we cannot go for LASIK. Then myopia range, if it is less, then hyperopia. Then basement membrane dystrophy, contact sports, all these things you can see, irregular astigmatism. So all these things they will be good for PRK. And content dry eye will be, because there will be more dry eye after PRK than LASIK. So whenever patient has got moderate dry eye, never ever think of PRK. Rest of the contraindication they are same as in LASIK. So it is very simple procedure. First we debride the epithelium with alcohol, then over that we do the excimer laser. So procedure is not very difficult. So post-op again care is not very difficult, just we have to go use topical steroids, and more than that we have to use lubricating drops. All these patients of refractive surgery, they develop dry eye at least for 6 months. So then till 6 months we must ensure that they are getting proper lubricating drops and topical steroid and antibiotic. That is the only treatment required. Thank you very much.